previous year we did for second MBBS student. The third year pannom community medicine. This year we have started for second MBBS students. Today we have Dr. Anusha with us. She is professor of pharmacology in Sri Ramachandra Medical College. So she will discuss on the part 2 of pharmacology, CVS, CNS and stuff. So welcome, ma'am. Thank you so much for consenting to take the session. So yes, Kavita, you please start the NMO mantra and let the session start.
Okay. We'll start with chanting Om thrice and followed by the mantra. Om. 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 Natvaham kamaye rajyam न स्वर्गं न पुनर्भवं कामये दुःखतप्तानां प्राणिनां आर्तिनाशनम्. Meaning, I do not seek for the kingdom, heaven, or even rebirth. My only desire is to remove the suffering of those in pain. As the NMO mantra conveys, the true purpose of a medico goes far beyond the personal gain. It is to serve society with compassion, selflessness, and commitment. So, with that, ma'am, you can take the session forward.
Good evening, all. Thanks, Moni Madam, for this opportunity. Dear students, am I audible?
Yes, ma'am, you're audible.
Yes, ma'am.
So you can see the screen, full screen, slideshow. I have started. Is it clear? Yes?
Yes.
Yeah. So good evening, all. Students who are all appearing for your exams for second MBBS Pharmacology paper 2. So generally pharmacology is a bit tough and volatile subject. And when you come to paper 2, you find because of paper 1, you will be concentrating more. And paper 2. But we are having more essay questions from these topics. Today, central nervous system, cardiovascular system, and part of diuretics I am going to cover. In central nervous system, to start from this, we have to start with sedatives, hypnotics topics because these drugs will be continued in epileptic drugs also. So to go into the brief, how I have planned this, I am going to touch the topic. I will be concentrating more on the essay questions and which area you have to read, from where you will be getting more MCQs, more essays and short. In sedatives, hypnotics, you will be getting the questions of therapeutic uses of benzodiazepines, and you will be getting a question of pharmacotherapy of insomnia. And then I think more questions won't come from barbiturates, but you have to know those topics. Then only it will be find easy in reading epileptic drugs. And Z compounds is an important short note. So you'll be getting 3 important short notes from this area. So to know about these drugs acts on the GABA. We all know GABA acts in the ligand-gated channel. So we have barbiturates, long-acting, short-acting, and ultra-short-acting. Nowadays, we are using only thiopentone sodium for induction of anesthetic agents. So anesthesia, with general anesthesia, is a separate topic. So thiopentone is given for induction of, so if you give inducing agent, the second stage of anesthesia can be prevented. And phenobarbital, we all know it is an enzyme inducer. It induces the metabolism of the co-administered drugs. And next comes the benzodiazepines. So benzodiazepines, we have hypnotic. It has a role of anti-anxiety and anticonvulsant. So we have diazepam. So I know you all find difficulty in remembering all the drug names. Remember diazepam, nitrazepam is a long-acting drug, and alprazolam has an additional feature of anti-anxiety property also. And then we have anti-anxiety agent diazepam, chlordiazepoxide, lorazepam, alprazolam, and anticonvulsants also we have diazepam and clonazepam. And we have Z compounds. They are the zopiclone, zolpidem, and zaleplon. So remember this one. So just I'm going to tell the outline. This is the GABA. In the same GABA, we have different binding site for benzodiazepines and barbiturates. Both will open the chloride channels by acting on these drugs. Yes. So here we can see barbiturate is also binding on the same GABA and benzodiazepines also binding on the GABA. So I think flumethylene is an important MCQ for you. Flumethylene is actually used in the treatment of diazepam overdose or poisoning. So there is a separate benzodiazepine receptor and barbiturate binding site. So they have GABA facilitatory and GABA mimetic action. So the important question, as I told you, therapeutic uses of benzodiazepines, you can write sedative, anti-anxiety property. They are also used in the treatment of epilepsy. We use chill diazepam in the status epilepticus. We can use lorazepam, and nowadays we are giving midazolam for febrile seizures and other conditions. They are having muscle relaxant property. So when you give IV diazepam, we can see the respiratory muscles will be paralyzed. So should be very cautious. Yes. So we have, when the treatment of insomnia is coming, I will tell in the next slides. In this, benzodiazepine and barbiturates, they act as a sedative and hypnotic. They will prolong the sleep duration. But what happens is, they have a lot of side effects. The next day hangover will be there. So to avoid this and to the patients, we can give for the treatment of insomnia, we can go with non-benzodiazepine compounds or benzodiazepine-like drugs. They are also called as Z drugs. So you have three types of questions. Z compounds, they may ask, non-benzodiazepines they are. The important drugs are the zopiclone, zolpidem, and zaleplon. They also bind on the same benzodiazepine receptor but at a different subunit. They act as a sedative and hypnotic. They produce a minor alteration in the sleep pattern. So you have to tell your patients after taking this drug, they will be getting sleep within half an hour. But they do not have the muscle relaxant property or anticonvulsant property or anti-anxiety property like a benzodiazepines. They will produce minimal rebound. What do you mean by rebound is, when you give a drug for a longer duration and when you suddenly stop the drug, you will get a negative effect. That is called rebound effect. It won't be seen in Izarcom. Same thing, it will reduces the sleep latency, and zopiclone has a longer half and it also decreases the nocturnal arousal. So when you treat insomnia, the patient will tell you a different thing. Many will tell my sleep starting time is delayed. Many will tell I will be getting frequent arousal. Many will tell early morning awakenings. Many will be associated with the phobia and anxiety. So you have to treat the basic cause. So now we all know about melatonin. You might have read in your physiology and other things. So melatonin will affect the circadian process. So melatonin also nowadays widely given. We have drugs giving melatonin, rameltion. They are also used in the treatment of insomnia. So it will produce a physiological hypnotic. So it will have a characteristic of the normal physiological sleep. It also facilitate both the onset and the maintenance of sleep. So where we use these drugs, whenever many are traveling abroad, they may have a jet lag, or shift workers, night duty workers, chronic insomnia and elderly, these drugs are used. So how we are planning to treat a patient with insomnia? So as usual, always first don't go with the drugs, give some non-medical managements, give some counseling, sleep hygiene, everything you teach. And then, as I told you, sleep onset, you can give melatonin and Z compounds. For maintenance, you give Z compounds. In older adults, go with melatonin, rameltion. If it is associated with depression, you can go with mirtazapine. If it is associated with anti-anxiety, go with anti-anxiety. Okay, so insomnia is an important short note for you. With this background, so now you got an idea that benzodiazepines and barbiturates acts on the GABA receptors. As I already mentioned, they have anticonvulsant property also. Anti-epileptic drugs is a frequently asked essay question. Okay, before going into this, how we are going to, what is the important pathophysiology of seizures? If you understand, you can easily remember the drug names. So here the problem is there will be increased excitatory amino acids. So students, if you have any doubt, please note it down. At the end of the class we will discuss. So there will be either increased excitatory amino acids or increased sensitivity to excitatory amino acids. So there will be an increase in glutamate release. So, and there will be decreased GABA, decreased binding of GABA and benzodiazepines and decreased response to GABA. So now you can easily tell how we are going to manage the patient. You are going to inhibit the excitatory and you are going to potentiate the inhibitory transferase. Yes. So always the balance should be maintained between the sodium channels and then even the tight calcium current responsible for absence seizure. So I think I'm not going into detail about the types of seizure, everything. So the important thing you have to remember is generalized tonic-clonic seizure, partial seizures, it may be simple or complex. If it is complex, it is associated with unconsciousness. And then we have a different type of seizure, that is absence seizure. So for absence seizure, we have to give drugs that acts mainly on the T calcium currents on the thalamus. For the other seizures, we can give other drugs also, like generalized tonic-clonic seizures and partial seizures. So here we can see the important problem is the increased sodium channel activity and increased excitatory activity, decreased inhibitory activity and decreased sensor response to GABA. That leads to epilepsy. So how we are going to strategy your management? You are going to give drugs. In your textbook, there will be a chemical classification. That is also you have to read. But to remember easily the number of drugs and how to remember the mechanism of action, you can read like this. That is, the drugs that stabilize the membrane and prevent the depolarization by acting on sodium channels. The drugs, as I already told you, we need for anti-epileptic management increased inhibitory neurotransmitter. So we should have increased in GABAergic transmission and we want the glutamate level to come down. So you decrease the excitatory. So see, what are the drugs? Yes, these are all also another classification. These are all the classical drugs like phenytoin, phenobarbital, these drugs, valproate, and we have the newer drugs. So actually older drugs are very good, but they have lot of side effects and we have this newer drugs. Yes, this classification I want you all to remember to easily remember the mechanism of action. So first, the drugs that inhibit the sodium channels are the carbamazepine, lamotrigine, phenytoin, valproate. Remember, whatever the drugs I'm stressing you, you at least remember those drug names. The drugs that potentiate GABA are the barbiturates, benzodiazepine, gabapentin, tiagabine, topiramate, valproate, and drugs that acts on the calcium. As I already told you, these drugs are going to act on the absence seizure, ethosuximide and valproate. So now you can notice one drug in coming in all the areas, valproate, acting on sodium, acting on GABA. So this drug is called as broad spectrum anti-epileptic agent. Sodium valproate is a frequently asked short note for you. And if it comes as an essay in anti-epileptic drugs, you will get add a note on valproate. Okay, it is very important and it's a broad spectrum agent. So how you have to remember is these drugs, the drugs acting on the sodium channels, they are widely used for partial seizures, generalized tonic-clonic. Drugs acting on GABA, they are also used for status epilepticus, this benzodiazepines, and these drugs are also used for generalized tonic-clonic and partial seizures. So this is the chemical classification given in your book. Identoin, we have the barbiturates derivatives, and we have the succinamide, ethosuximide, immunostilbin, carbamazepine, GABA transaminase inhibitor, valproate, and benzodiazepines. So excitation is too much, inhibition is little. So ionic currents and so why I am repeating is if you remember like this, you can easily remember the mechanism of action. Yes. So we have the phenytoin and carbamazepine. They block the voltage-dependent sodium channels at high firing frequencies. Even we are seen in local anesthetic agents, is it not? They inhibit the sodium channel. When the sodium channel is inhibited, there won't be a progression of the nerve. Here we can see this is the open sodium channel. This is the activation gate. This is the inactivation gate. Now we see, so when you inactivation gate, the sodium channel, yes, sorry. So it will get open. Now, if you see, if there is, this is called as a high frequency sodium channels. So the drugs like carbamazepine, phenytoin and felbamate and lamotrigine, they block the activated sodium channel and make it inactive. So what happens? The further progression of the nerve impulse is prohibited. So barbiturates and topiramate also have mild effect. They block the channels firing at high frequencies. So as I already told you, valproate is a broad spectrum agent. It blocks the GABA. It enhances the GABA effect by inhibiting the GABA transaminase. They block the voltage-gated sodium channel. They block the T-type calcium current. So here we can see. So this is drugs acting on the GABA, benzodiazepines and barbiturates. They favor the chloride openings. The drugs like topiramate, they act, and this GABA is converted to succinic semialdehyde with the help of the enzyme GABA transaminase. This enzyme is also getting, so when this enzyme is there, it will be converted to a metabolites. So what happens? We have decreased GABA, but now we want increased GABA. So we have drugs that inhibits the GABA transaminase, and we have gabapentin. It acts like an agonist on GABA. The exact mechanism of action is not clear. And we have the valproate, which inhibits the GABA transaminase enzyme, and there will be increased GABA effect. Vigabatrin also shares the same mechanism. And we have the gabapentin and tiagabine. So always, whenever a neurotransmitter is released, what happens? There will be a reuptake mechanism. This reuptake mechanism is inhibited by tiagabine. So these drugs will potentiate the effect of GABA either by directly facilitating, like benzodiazepines and barbiturates, by facilitating and mimicking, by inhibiting the metabolism like valproate and vigabatrin, and then by inhibiting the reuptake, we have the gabapentin and tiagabine, and directly acting agonist and unknown mechanism is the gabapentin. So this is the reuptake inhibitor. So this you all remember. So we have the gabapentin, the access and GABA analog. Where we use gabapentin, it is an add-on anti-epileptic agent. It is not a main anti-epileptic agent. Nowadays, we use gabapentin for neuropathic pain. This is again an MCQ for you. And the broad spectrum anti-epileptic is an important MCQ for you. And you have to remember the adverse effects. So we have seen phenytoin and carbamazepine. So in this phenytoin, these both act on the sodium channels. Phenytoin is a very good drug, but not for absence seizures, only for generalized tonic-clonic seizures. The important thing you have to remember in phenytoin is they have more toxicity. They have dose-dependent toxicity. From hirsutism, vitamin K deficiency, osteomalacia, it produces hirsutism, and even in toxic concentration, it produces cerebellar ataxia. Likewise, you have to remember for carbamazepine. Carbamazepine is a drug which is more prone for hypersensitivity reactions, and carbamazepine also produces aplastic anemia. So whenever a patient is put on carbamazepine, frequent blood counts should be monitored. We have the vigabatrin, which is irreversible, and it also potentiates to cause psychosis, and tiagabine, we are seeing the uptake. Yes. So nowadays, more drug use is levetiracetam. So there is a more possibility of getting short motion in levetiracetam. It is also an adjunctive therapy. First, I told you in a slide, no, classical and newer agents. The classical agents are widely used. So the other newer agents are nowadays widely used as an add-on therapy. They have a peculiar action. They bind to the synaptic vesicular protein SV2A. They modify both glutamate and GABA. So they may produce some renal toxicity. So, but it won't have those neuronal side effects what produced by phenytoin. And barbiturates, once upon a time, it was a very good drug as an anti-epileptic agent. Those drugs are widely causing mental retardation and weight gain, and phenytoin and phenobarbital are inducers. So that you have to remember in kinetics. So they may induce the metabolism of the co-administered drug. Yes, this is also an important short note, and you will be getting as a add a note on status epilepticus. So whenever there is a continuous episodes of seizure, that is the abnormal movements for more than 30 minutes, when it's sustained, then it is called a status epilepticus. So we have to give in this time benzodiazepines. Generally, benzodiazepines and barbiturates, they produce more tolerance. So we won't use these drugs as a prophylactic measures. So though they are anti-epileptic drugs, benzodiazepines are used only in emergencies like status epilepticus. So we can give diazepam or lorazepam. We can give intravenously, followed by phenytoin and fosphenytoin. We can give when the patient is not at all responding. So initial management you have to remember is you have to give mouth gag. You have to put the patient in the left lateral position to avoid the tongue bite and to prevent the aspiration. And other things you have to maintain IV. You can give lorazepam and then followed by phenytoin. If not settling by anything, you have to anesthetize the patient. Yes, this is very important. Febrile seizures. It is very common in less than 5 years of age. It is will be associated whenever the temperature is rising, the child may throw seizures. For this tepid sponging, and we can give diazepam diluted dose. As I already told you, diazepam is a muscle relaxant. So you have to give diluted diazepam. Slowly we have to give with ambubar, and then even you can give midazolam drip. Nowadays, buccal midazolam also coming. The actually febrile seizures will get treated by itself once the child reaches the age of 5 or 6. If it is persisting after that, there may be a organic issues that has to be treated. This is again an important MCQ for you. Alternate use of anti-epileptic drugs. As I already told you, carbamazepine is widely used for neuropathic pain, particularly post-herpetic neuralgia, gabapentin for diabetic neuropathic pain, and lamotrigine and carbamazepine are also used in the treatment of bipolar disorder. Levetiracetam, valproate, topiramate, the gabapentin, they are also used in the treatment of migraine prophylaxis. Yes. So far, any doubt anyone having? I think you can, I don't know how you have to ask. Sir, they can ask us, sir. All having the option of unmuting us, sir. Yes, the organizer, Jitesh or someone. Can anyone answer me?
Yeah.
You people can unmute and ask doubts, sir, in between.
Yes, ma'am.
Yes. So, can you all follow me? Am I speed? Shall I continue?
Yes, ma'am.
Yeah. So next we are going to see is the Parkinsonism. It's a progressive neurodegenerative disorder. So there will be a degeneration of the substantia nigra. So here there is a decreased dopamine level, and always there is a balance between dopamine and acetylcholine. When dopamine comes down, acetylcholine level will increase. So we can plan the therapy like the drugs that potentiate the dopaminergic level, the drugs that blocks the central cholinergic effects. So we have the characteristic feature of the Parkinsonism is we all know, rigidity, and then they have a forward tilt of trunk, reduced arm swimming. There will be lead pipe rigidity will be there. They will be having tremors and shuffling. Yes. So as I already told you, you have to give drugs that is going to enhance your dopaminergic activity. So we have drugs acting like levodopa. So dopamine cannot penetrate the blood-brain barrier. So we have to give levodopa, which then cross it and then it will be getting converted to dopamine. And we have the dopaminergic agonist drugs, bromocriptine, pergolide, and then we have drugs that inhibits the metabolism of dopamine. That is monoamino oxidase inhibitor like sertraline. And we have drugs like amantadine. Actually, it is an antiviral. It is again an MCQ for you. Which antiviral drug is used as the treatment of Parkinsonism? That is amantadine. And the next is the reduction of the cholinergic activity by centrally acting anticholinergic drugs. So these are all the drugs. Levodopa converting to dopamine, and we have amantadine. They have drugs acting directly on the dopamine receptors, and we have drugs like sertraline, which inhibit the monoamino oxidase, and amantadine. So when you give levodopa alone to a patient, so you can see 100% levodopa you are giving, but in the blood it will go off by peripheral decarboxylase enzyme, and then it will get metabolized in the tissues and in the periphery. Only few will enter the brain. To prevent this, what you can give is, you can add carbidopa. This drug will inhibit the peripheral decarboxylase. So more levodopa can penetrate the blood-brain barrier. So we have the drugs like triacylphenidil. So these are all the centrally acting drugs. So can anyone guess which drugs produce Parkinsonism? Yes. I think students cannot answer, I don't know. So we have antipsychotic drugs. These drugs mainly block the dopamine D2 receptor. That is their mechanism of action. These drugs will produce drug-induced Parkinsonism and extrapyramidal symptoms. For treating this, you can't give them dopamine, is it not? Because those drugs have blocked your D2 receptors. So what you are going to give? You are going to give drugs which is going to antagonize the central cholinergic effect. So you are going to give centrally acting anticholinergic drugs like triacylphenidil, piperidine. They benefit Parkinsonism by blocking the acetylcholine receptors in the CNS. So they will improve the tremor, rigidity, and silence. So we all know anticholinergic drugs. We won't give atropine. We are going to give only selective agents. The general side effects like dry mouth, blood effusion, those will be there for this centrally acting anticholinergics. So in anti-Parkinsonism, what you have to remember is, we have to remember about levodopa, why carbidopa and levodopa is added together, and coming to the drug interaction. So what happens when you give any multivitamin? The two mainly drugs containing vitamin B6, they are all potent inducer. They will hasten the metabolism of levodopa. So there will be less drug available for circulation. So that interaction you should remember. And then levodopa. And then we have dopaminergic agonist drugs also, ropinirole. And those drugs are also important. And you have to remember about the MAOB inhibitors. When MAO inhibitors comes, important MCQ, you will get the cheese reaction. That is, when you give MAO inhibitors with their cheese containing food or a tyramine containing food, what happens is there will be more, because this is going to inhibit all adrenaline, noradrenaline, and dopamine, monoamino oxidase. When you give these inhibitors with tyramine containing food, this will produce cheese-like reaction, that is the hypertensive crisis. So we have seen now benzodiazepine, hypnotics and sedative salient points we have seen, importance of anti-epileptic drugs, and we have seen about anti-Parkinsonism. You will get levodopa as an important short term for you. The next topic is opioid analgesics. In this topic, you will be getting an essay question. Classify opioid analgesics. Explain in detail about morphine. They may ask you, add a note on morphine poisoning also they may ask you. So we all know analgesics are the terms, that is the drugs which and all are going to reduce pain. What are the important analgesics we know? We have NSAIDs. non-steroidal anti-inflammatory drugs. The name itself tells they are all used in the treatment of pain associated with inflammation. So for the visceral pain, for organ pain, we have to give opioid analgesics. For example, when a patient coming to you with some injury followed by some inflammatory changes, you will give NSAIDs. You may give diclofenac, aceclofenac, Brufen or other drugs. But when a patient coming to you with myocardial infarction, severe cardiac pain, anginal pain, what drug you give? You won't give NSAID. You will give morphine, that is opioid analgesics. These drugs are all for the visceral pain. So opioids are the drug which binds to the opioid receptors. They are the mu, kappa and the delta. So these drugs have both supraspinal and spinal effects. So they act on the CNS above the spinal level, under the spinal level, and they will stop the progression of the pain. So we have synthetic drugs and we have natural compounds also. Opioid is obtained from the natural compound morphine plant. So we have, that is the poppy. So we have antagonist for this is the naloxone. Actually, you won't get morphine from any medical shop. It comes under narcotic register. So it will be maintained in certain hospitals only. After the double lock system only, you can get opioid analgesics. Why it is very clear is these drugs are more prone for tolerance and dependence also. So we have the opium. So we have the natural compounds like morphine, codeine, thebaine, and then papaverine, nascapain, and those things. Where we have studied codeine. Codeine you will be reading in respiratory system. Codeine, full codeine, they are all used as the cough suppressants also. Nascapain also. So what these drugs will do? The pharmacological action of this drug is they are all CNS stimulants. They sensitize the CTZ zone to so more vomiting will be there and there will be constriction of pupil. Here it is a different constriction of pupil. In pilocarpine, physostigmine, we have constriction of pupil, but that and all are produced by constriction of the sphincter pupillae muscle. Here we have different. These drugs acts on the Edinger-Westphal nucleus. Thereby, they produce constriction of the pupil on the opposite side. So, they produce bradycardia and they also produce respiratory center depression. So that only these opioids are highly contraindicated in head injury patients. Whenever a patient is coming to you with head injury, don't give opioids. Even the patient suffer with pain. So they suppress the respiratory center, they suppress the cough center. So that only I told you we can use codeine, full codeine in the treatment of dry cough. They also suppress the temperature center, they also suppress the vasomotor center. So there will be fall in BP. So when you are very clear, always when you read any drugs, don't go directly to users and side effects. First read pharmacological actions. Now, once you read the pharmacological action, now you itself can write the contraindications and uses and adverse effects. So, morphine has a stimulant effect and it also have the dampening effects on the pain. They have analgesic action. As I already told you, antitussive, cough suppressant activity. They have analgesic property, anti-diarrheal property. So codeine is also used in the treatment of diarrhea. Off-label use will be in the treatment of diarrhea. Yes. So what are the other therapeutic uses of morphine? They are used as a pre-anesthetic medication. So before any surgery, if the patient is suffering with pain, you can give morphine. Balanced anesthesia and surgical analgesia. Many studies have proved morphine works well in cardiac asthma. That is for the acute left ventricular failure. So in the cough, we won't use morphine. As I already told you, we use codeine, full codeine. And diarrhea, that is the post-colostomy patients, we use the drug loperamide and diphenoxylate. Yes, this is very important. Morphine uses, adverse effects, we have to read the contraindications. Yes, morphine is contraindicated in 2 extremes of age. Don't prefer in children, don't prefer in elderly. And all morphine group of drugs are actually, I think you will be getting in pharmacology practicals. In your practicals, there will be exercise that it produces Stropp's test. That is, morphine will constrict the smooth muscle. It will constrict the anal sphincter, and it also will produce the tail erection response. And then, so they are absolutely contraindicated in colicky pain. As I already told you, morphine is more preferred in organic pain, that is visceral pain. But don't give to patients suffering with colicky pain, like biliary colic, because morphine is a smooth muscle constrictor. So it will constrict the smooth muscle. So you are advised not to give morphine for asthmatic individuals, because there will be respiratory smooth muscle constriction will be there, and they also constrict the biliary smooth muscle. And morphine is contraindicated in head injury because it will suppress the respiratory center. And don't give patients in shock, hypotension. As I already told you, it will depress the vasomotor center. Don't give for undiagnosed acute abdomen. It may be a cholecystitis, it may be even a biliary colic. And then don't give for renal failure, liver disease, hypothyroidism, and unstable personalities. So this is the classification you should remember. Natural opium alkaloids, morphine and codeine. Semi-synthetic, we have the heroin and fulcodeine. These drugs, they are all coming under narcotic groups. And we have the synthetic opioids. We have the pethidine and its congeners. We have the fentanyl, remifentanil. These drugs are nowadays used coming even in transdermal patch for the treatment of pain. And we have the methadone. Methadone is an important MCQ for you. Methadone is used in the treatment of, as I told you, why we are, though morphine is a very good analgesic, we won't give morphine continuously because it will produce tolerance and dependence. So what happens, after you give morphine sulfate for longer duration, they won't have analgesic property at all. But morphine, again, it's an MCQ for you. Tolerance will not develop to constipation. It will inhibit the peristaltic movements. So it will produce constipation. And pentazocine we have, and levorphenol, morphine compounds, and the butorphanol. So these pentazocines are widely used in the MI pain. Sorry, there's some skip. Okay. So what you have to remember in morphine is, you have to remember the classification. What are all the natural compounds? What are the semi-synthetic, synthetic compounds? Read the mechanism of action. Read the pharmacological action thoroughly. It has effects from head to head. So you have to remember it's a depressant, analgesic property, supraspinal, spinal, acting on the opioid receptor. It produces constriction of the pupil, depress the cough center. It is used in the treatment of left ventricular failure. They all constrict all the smooth muscles. So don't give in asthmatic individuals. Don't give for colicky pain also. And they are all the users. You should write about treatment of cough, antitussive property. And then you have to write about the use in the treatment of diarrhea, that is loperamide. Then next we are going to see about the depression. So again, in depression, so we have it frequently they may not ask essay questions in depression. If they ask, you have to remember all the classification. We have the, what happens in depression, the neurotransmitter levels will come down. Mainly the serotonin, dopamine, everything will come down. So what we will give is, we give drugs to improve these levels. We have the important agents are the tricyclic antidepressants. We have SSRI, and we have some newer antidepressant agents. So these tricyclic antidepressants, the name itself tells you, it is going to increase the level of all the things, epinephrine, norepinephrine, and then we have all the dopamine, serotonin. So when everything is increased, you all know there will be lot of side effects, tricyclic antidepressants. They may produce hypertension. And we have the other group of drugs, MAO inhibitors. We have studied MAO inhibitors B in Parkinsonism because that will inhibit the metabolism of dopamine. Here we are non-selective MAO inhibitors. They are all used in the treatment of depression. They inhibit the metabolism of both noradrenaline, adrenaline, everything will be inhibited. But these two groups of drugs, tricyclic antidepressants and the NMO inhibitors, they have more adverse effects. So nowadays we are not using those drugs for normal depression. They are used only for refractory depression or are some add-on agents. Nowadays we are widely using SSRI. SSRI is an important short note. Selective serotonin reuptake inhibitors. They are comparatively potent. They are comparatively safer drugs. They are the drug of choice in depression, anxiety, phobia, and obsessive compulsive disorder. So the merits of this drug, why we are using these drugs comparatively to tricyclic antidepressants is they won't produce sedation, no interference with cognitive or psychomotor. So you can remember these are all the side effects of tricyclic antidepressants and MAO inhibitors. They won't produce anticholinergic activity. They won't have alpha blocking property. They won't precipitate seizure. No adverse effect of seizure. The important drugs to remember in SSRI is we have the fluoxetine, duloxetine, citalopram, escitalopram. At least you remember these drugs. So these SSRI, apart from the treatment of depression, we are nowadays using these drugs to treat perimenopausal symptoms, vasomotor symptoms. Even duloxetine is used in the treatment of neuropathic pain. Nowadays, we can see many are taking antidepressants. So it's mainly for perimenopausal and menopausal symptoms. But SSRI do have the side effects. Actually, in depression, there will be more suicidal intention. But the problem with fluoxetine itself is suicidal intention. And another important thing you have to remember in this SSRI is these drugs will take at least 6 weeks to work. So you have to, the therapy should be given for at least 6 weeks. So these are all the important points you should remember in SSRI. And these drugs itself will produce suicidal intention. So this has to be intimated to the patients. So we have these atypical antidepressants. They are also called as the newer antidepressants. They are the venlafaxine. They are all selective SNRI. They inhibit both serotonin and norepinephrine. So they inhibit the 5-hydroxytryptamine and noradrenaline reuptake. They have faster action. Sustained increase in BP will be there. That is with venlafaxine. Nafazolone is an important drug. It blocks reuptake of 5-hydroxytryptamine, norepinephrine, and antagonists 5-HT1. And we have the trazodone also. So the next important group of drugs. So in depressants, you should know about tricyclic antidepressants. You should know about MAO inhibitors. And then you should remember SSRI, so frequently asked questions, and newer antidepressants, or they may ask atypical antidepressants. There become the mirtazapine, and then we have seen about the venlafaxine, trazodone and all. In this mirtazapine and these group of drugs, even they are used in the treatment of fibromyalgia and neuropathic pain also. So this will be thing with depression. Next comes the antipsychotic drugs. This is also a very important question. Antipsychotic drugs. We have neuroleptic drugs, that is typical classic drugs and atypical drugs. In these typical drugs, we have the phenothiazines, that is the chlorpromazine, thioridazine, and we have the thiotixin, haloperidol group of drugs. So what these drugs, these typical drugs, why they have been called as the typical drugs is they all block dopamine D2 effect. We have already seen the side effects of these drugs is the extrapyramidal symptoms, Parkinsonism like features. To avoid all these side effects, we have the atypical agents, heterocyclic structured drugs, we have the clozapine, olanzapine, quetiapine, risperidone, ziprasidone, aripiprazole, and all. So in this, the frequently asked question is the chlorpromazine. Here we can see the correlation between the therapeutic potency and the dopamine. The higher the D2 blocking effect, they will have higher antipsychotic property. So the drugs which have blocking more D2, alloperidol, chlorpromazine, these drugs will have more antipsychotic property. They control both the positive symptoms and the negative symptoms also. But when it comes to clozapine, clozapine is a newer drug. It is an atypical antipsychotic drug. They doesn't have that much D2 blocking effect. Even they also act on the D4 receptor. One important MCQ with chlorpromazine is extrapyramidal symptoms. Again, they will ask another MCQ. Drug used in the treatment of this drug-induced Parkinsonism is centrally acting anticholinergic drugs. One more important MCQ in clozapine is they produce paradoxical response. They produce and they have anticholinergic property, but they produce increased salivation also. So all antipsychotic, what they are going to do? They reduce dopaminergic transmission. So the typical drugs, you easily remember like this. They are all D2 antagonists. They blocks the D2 receptor tightly. See? They blocks it tightly. Atypical is both serotonin and dopamine antagonists. Here we can see they bind a D2 receptor not tightly. They also bind it to 5-HT2 receptor also. They have low affinity to D2. High affinity to 5-hydroxytryptamine. So, atypical antipsychotic drugs will not produce extrapyramidal side effect like your typical antipsychotic drugs. Yes. Here the binding is tight. Here we can see the binding is loose. So, atypical dissociate rapidly. So, what happens? The risk of side effects is minimal. So this typical is D2 antagonist. They may be 5-HT2 antagonist. They are D2 antagonist also. They also have antagonism of histamine, muscarinic, and also. In this, in psychotic, antipsychotic itself, they will be having a separate question, either mood stabilizer or treatment of mania disorder. Here comes for mood disorder, mania. So what is mania? They may have extreme of effects. They may have depression. They may have psychosis. So here the drug of choice for this condition is lithium. Lithium is an important short note for you. So lithium is a drug. You have to remember the important side effects. In CNS, more drugs will have more side effects. So while reading itself, you underline all the side effects and make a note of all side effects. It will come as an MCQ to you. For acute manic episodes, you have to give the drug lithium. For other drugs, as I already mentioned, no, we have carbamazepine. We have seen as an anti-epileptic drug. It is used in the treatment of post-herpetic neuralgia. It is used in the treatment of neuropathic pain. Carbamazepine is also used in the treatment of bipolar disorder. And valproate also used in bipolar disorder. We have even calcium channel blockers can also be used. The newer antipsychotic drugs, as I already told you, they have less affinity to D2 receptors. They have more action on 5-hydroxytryptamine. We have so you can't remember all the drugs. At least remember clozapine, olanzapine, quetiapine, risperidone, ziprasidone. So we'll take a break. Yes, you all can hear me?
Yes, ma'am.
Ah, okay. The next we are going to see is the cardiovascular system. So we are going to see about anti-anginal drugs. We are going to see about nitrates. So sorry, I mentioned in CVNS, we missed alcohol. So alcohol as such, it has no therapeutic property. So only thing, it may be used as an antiseptic agent. So in alcohol, you have to remember one important short note is treatment of methanol poisoning. Here you have to avoid the patient to expose to light. They should be in the dark room. They have to be closely monitored. Here the problem is there is more possibility for blindness because this alcohol, when it is metabolized by the enzyme alcohol, whenever there is a poisoning of methanol, alcohol will be converted to acetaldehyde. But when you give methanol, methanol is in the poisoning, it will be converted to formaldehyde and formic acid, which may damage the eye. That is the important problem in methanol poisoning. So how we are going to treat the patient? Admit the patient, avoid exposure to light because it may damage the eye, and then give them fomepizole. And actually the treatment for methanol poisoning is ethanol because the problem in methanol is the conversion to formic acid. What happens? The aldehyde dehydrogenase, instead of metabolizing methanol, if you give ethanol to the patient, it will inhibit that and start metabolizing ethanol. Ethanol will be converted to acetaldehyde and acetic acid. So that is the rationale of giving ethanol in methanol poison. That is an important short note for you. One more topic we missed in CNS is the general anesthetic agents. What you have to remember in general anesthesia is the stages of anesthesia. So in this, the second stage is a important stage, that is the delirium and all. So we have to give drugs to reduce the second stage of anesthesia. That is an important MCQ. We give the inducing agent is the thiopentone sodium. We have seen in the barbiturate topic. So thiopentone sodium is used as the induction agent in the to reduce the second stage of anesthesia. And then we have inhalational anesthesia, and then we have drugs for IV. So inhalational anesthetic agents are, we have the other drugs like nitrous oxide, and you have to remember for nitrous oxide, you have to remember the second gas effect and diffusional hypoxia. It is an important MCQ. And ether nowadays we are not at all using. Read about enflurane, sevoflurane, and this enflurane you can remember EE. It is contraindicated in epileptic patients. Sevoflurane is widely used for short procedures. We have ketamine. Ketamine is an important short note for you. Ketamine, what you have to remember is produce dissociative anesthesia. That is, when you inject ketamine to the patient feels that he himself will get dissociated from the surrounding. That is an important MCQ for you. And ketamine can be given intravenously. It produces increase in BP. So better avoid in patients suffering from hypertension. So hypertensive patients don't give ketamine. I'm unable to open my camera, pa. Why? Anyone? So this you all remember, should remember in general anesthesia. Read about halothane. Halothane will sensitize the heart to arrhythmic changes that you have to remember. Malignant hyperthermia, you have to remember. Read about ketamine is an important short note for you. And the other important short note you get in general anesthesia is the pre-anesthetic medication. The name itself tells pre, that is, before any procedure involving general anesthesia, what are the drugs? It's an important short note for you. So the patient may suffer from pain. So you can give an analgesic agents. So the day before surgery, the patient will be anxious. They cannot sleep. So you can give an anti-anxiety drugs. You can give a benzodiazepines to aid in sleep and to reduce the anxiety. They will be in fasting stage, So they will be having more acidic secretion. Give drugs that reduce the acid secretion like H2 blockers and proton pump inhibitors can be given as an anesthetic agent. And whenever general anesthetic agents are given, they are more prone for vomiting. So you can give them, they are anti-emetic agents. So the important pre-anesthetic medications are the analgesics, and then we have to give sedatives, anti-anxiety drugs, drugs to reduce acid secretion, and then drugs to reduce vomiting. This is the important short note pre-anesthetic medication. So far, we have touched a few points here and there in CNS. Next, we are going to CVS and diuretics. Here, we are more going to concentrate on the angina, hypertension, heart failure. Yes. So, we all know angina is a typical chest pain. So, the pain will get aggravated on exertion. It may relieve. If it is a stable angina, it will relieve by taking rest. So, yes. What happens in the normal heart? There will be always a maintain between the oxygen supply and the demand. So whenever there is any exercise, if the patient do also, the balance will be maintained if the heart is normal. So the supply and the demand. But when the heart is having a coronary artery disease, the supply will decrease and the demand will be more. So we have three types of angina: classical angina, we have the vasospastic angina, unstable angina, that is the acute coronary syndrome. So the oxygen delivery, what you are going to improve? So the patient, there is a atherogenic block or any other thing or vasospastic angina that reduce the blood supply and the oxygen supply to the heart. So what you are going to do? You are going to give drugs that will give some oxygen delivery or that will improve the blood supply to the heart, or otherwise you can decrease the oxygen demand and you can redistribute the available oxygen. So what are the drugs that are going to improve the oxygen delivery? They are your vasodilators, nitrates, calcium channel blockers, potassium channel activators. And then we have the beta blockers. It is going to decrease the oxygen demand, and nitrates and CCB can also contribute. Yes. Vasodilators and beta blockers and CCBs. The important drugs: short-acting drug, glycerol nitrate. What is important you have to remember? Nitrates can be given sublingually in case of acute pain so that they will be increase in the bioavailability. They bypass the liver. We have the long-acting drugs, isosorbate dinitrate and mononitrate, which are available in the tablet form given for the prophylaxis of angina. And then even glycerol nitrate, if you go to cardiology IC, you can see it will go in drips, NTG drip. And then nitroglycerin can be given in IV infusion. And we have the cardio-selective beta blockers. Remember here, cardio-selective like metoprolol, atenolol, bisoprolol, and celiprolol. And calcium channel blockers like the verapamil, diltiazem, nifedipine, amlodipine. Potassium channel openers, nicotinamide, and others. The important drugs are the trimetazidine and replacement. Anti-anginal drugs is an important essay question. Nitrates is an important short note. In this, another important short note is the treatment of myocardial infarction. So nitrates, you all know, it's a nitric oxide donor. So it will produce the smooth muscle relaxation. They produce more venodilatation and they are all venodilator, dilates the coronary vessels, and they also redistribute the blood flow to the ischemic area. They decrease the oxygen demand and they also improve the oxygen supply. So next is the beta receptors, cardioselective beta receptor. They inhibit the beta receptors in the heart. So thereby they decrease the heart rate and the contractility. They decrease the cardiac output and they can be given along with vasodilators. One thing you have to remember is verapamil should not be combined with beta blockers. Verapamil also will depress the conduction and beta blockers also will depress the conduction of the heart. But we can give calcium channel blocker group of drugs. We can give dipine group of drugs. Nifedipine, amlodipine. This can be combined with a beta blocker. Again, it's an MCQ for you. Verapamil should not be combined with non-selective beta blockers. And this calcium channel blockers will produce reflex tachycardia. Important side effect of beta blocker is bradycardia because they are going to depress the heart. The next important drug is the calcium channel blockers. We have the verapamil, diltiazem, dipine group of drugs. And they all block the L-type calcium channels. So they decrease the contraction of the heart and verapamil and diltiazem also inhibit the contraction of the heart. Here we can see this is the mechanism of action of calcium channel blockers producing vasodilation. So here you can remember except verapamil. Verapamil will decrease the heart rate, but nifedipine actually they all produce reflex tachycardia. This is an important MCQ for you. They decrease the peripheral vascular resistance. They decrease the, see, calcium channel blockers is a separate short note. Nitrates is a separate short. They decrease the myocardial cardiac workload. They decrease the oxygen demand. And potassium channel activators is a separate short note. Nicotinamide, phenazidil. These drugs, they are also nitric oxide donor and they produce increase in cyclic GMP level. So what happens? There will be vasodilator activity. There will be smooth muscle relaxation. So there will be more blood supply to the heart, more oxygen supply to the heart. We have novel anti-anginal drugs, trimetazidine and ranolazine. How they act is, they decrease the fatty acid metabolism. They improve the glucose metabolism in myocardium and they conserve the stores, ATP stores. That is the mechanism of action. They use the alternate. So whenever we all know, whenever the glucose level comes down, what will get activated? Fatty acid oxidation will activate. Here it will inhibit. So angina for myocardial infarction is a separate question for you. For this, we have to give in the treatment of pain, we have to give what drug? We have to give opioids group of drugs, pethidine group of drugs in the treatment of pain. And then the patient, according to the blood pressure, you have to give NTG if it is low or high. If it is low, you have to give some pressure agents. And then for what drugs to be given? It is an infarction. So what you have to give? You have to give a fibrinolipase. Like altiplase, streptokinase can be given. And the next group of drugs we can give if it is a unstable angina. Otherwise, you can give heparin, anticoagulants can also be given. And then for prophylaxis of MI, so we can give beta blockers, nitrates. They have to be given lifelong, and you have to give antiplatelet agents like aspirin, which is actually in NSAID. NSAID like aspirin at a low dose can be used as an antiplatelet agent. So treatment of MI is a separate short note for you. You have to write both acute pain and how you are going to treat the prophylaxis. The next important essay question is that antihypertensive drugs. So yes, very easy. You can write about all the drugs you can know, antihypertensive drugs. So How you can tell is antihypertensive either reduces the cardiac output or peripheral vascular resistance. They are all controlled by three important mechanisms: baroreflex, renin-angiotensin aldosterone, and local release of hormones. We'll see one by one. Increase in blood pressure is because of increase in the cardiac output. What is BP is equal to cardiac output into peripheral vascular resistance. So what you are going to give? The drugs which and all are going to decrease the peripheral vascular resistance. That is the drugs which are all producing vasodilation, and the drugs which is going to decrease the cardiac output like beta blockers can be given. The four sites important in the treatment. How to remember antihypertensive drugs? Drugs acting on the medulla. That is a central sympathetic flow. They are the centrally acting sympatholytic group of drugs like clonidine and alpha-methyldose. The drugs which are all directly acting on the heart like beta-1 receptors. The drugs which are all acting on the blood vessels. That is the drugs which are all going to reduce your peripheral vascular resistance like alpha blockers, vasodilators. The drugs that is acting on the kidney, that is diuretic group of drugs. So these four sites are the important. If you remember like this, you can easily remember the classification of antihypertensive drugs. See, here drugs acting on the CNS, we have the ganglion blockers, we have the clonidine alpha-methyl dopa, we have the angiotensin 2 receptor antagonist. They act on they inhibit the enzyme I will explain, and the drugs acting on the heart, drugs acting on the kidney like the diuretics, and drugs acting on the vessels are your calcium channel blockers, and there are other directly acting vasodilators. For the treatment, we have the non-pharmacological, restrict salt intake. You can advise the patient non-pharmacological that you can write. Pharmacotherapy, drugs decreasing the cardiac output, decreasing in the plasma volume. So mean arterial pressure is equal to cardiac output into total peripheral resistance. Yes. So we have the diuretics which prevents the sodium reabsorption. What is the role of diuretics? They increase the urine output. But the problem is along with urine, electrolytes also will go off. So in case of diuretics, so diuretics also comes under antihypertensive drugs also. And diuretics also is separate essay question for you. So I'm going to club here both. So diuretics, there are 4 and 5 important site of mechanism of action. First is the acting on the proximal tubule, that is the carbonic anhydrase inhibitors. The important drugs are the acetazolamide, dorzolamide. These group of drugs not used as a main antihypertensive agents. Acetazolamide, important MCQ, they are used in the treatment of mountain sickness. Okay, for the high altitude climbers, they can be used, and acetazolamide also used in the treatment of glaucoma. So this is the only oral agent used in the treatment of glaucoma to reduce the intraocular pressure. So before any procedure, these can be given. And another use, mountain sickness. The next important drugs are the loop diuretics. The name itself tells they act on the loop, sodium, potassium, ATPase. So they activate on this transporter and they inhibits the reuptake of the sodium potassium at the level, and they are all also called as the high ceiling diuretics. Loop diuretics and thiazide diuretics are high ceiling diuretics. They are highly effective. So loop diuretics are the furosemide. We at least remember furosemide. That's very important. And coming to thiazide diuretics, we have the chlorthalidone, hydrochlorothiazide. What you have to remember in thiazide diuretics is they are also acts as an antihypertensive agents. And the next, as I told you, not only they inhibit water reabsorption, that also getting, they also going to excrete the important thing like sodium and potassium. So how you can treat the patient? They will be going for hypokalemia, hyponatremia. So to prevent this hypokalemic changes, We have the other group of diuretics called as the potassium sparing diuretics. The name itself tells they prevent the hypokalemia side effects. They are potassium, they are all amiloride, triamterene, and spironolactone. In this, spironolactone acts have a different mechanism of action. They inhibits the mineralocorticoid receptor. This triamterene and amiloride, they act on the collecting duct on the activated sodium channel. So they have a different mechanism of action. So whenever loop diuretic is given or thiazide diuretic, generally they will give potassium supplements, or it can be clubbed along with these diuretics. So diuretics are widely used in the management. Thiazide diuretics for as an antihypertensive agents, and these loop diuretics and the potassium sparing diuretics are widely used in the management of edema, congestive cardiac failure. So congestive cardiac failure management includes diuretics. So you have to remember the mechanism of action of diuretics. So like if you remember this picture, you can easily remember the mechanism of action of all diuretics. Loop, thiazide, and this potassium sparing diuretics. One more diuretic is the osmotic diuretics. That is the mannitol and diazoxide, where we use mannitol in two different conditions, for acute congestive glaucoma and then for the cerebral edema. They are all osmotic diuretics, that is from the highly permeable to permeable membrane. That inhibition they will do, and they are used only in case of emergencies. Another important group of drugs in CVS is the AC inhibitors. I'm not going in separate detail. AC inhibitors, if they ask you, these are all widely used first stage of management for heart failure and then for your hypertension also. When AC inhibitors is asked as a separate question, you have to write both heart failure, hypertension also. So you can remember these drugs as the pril group of drugs. That is, what are the drugs? Captopril, enalapril, lisinopril. You can remember all these pril group of drugs. And these drugs have a common features. They are all pro-drugs. Actually, your levodopa and these group of drugs are inactive as such. When they undergo the first biotransformation, that is the phase 1 biotransformation, they will get converted to enalaprilat. So they will become active. That you have to remember. And then these are all RAS. RAS inhibitors is also a separate question for you. So these drugs. In this itself, we have angiotensin receptor blockers. They are the sartan group of drugs. Candesartan, irbesartan, telmisartan, losartan. These are all the widely used drugs. Yes, the outcome benefits nowadays it's increasingly used. What is, you all remember renin? Whenever there is a decrease in the blood volume, there will be renin. Renin will convert the angiotensin, first angiotensinogen to angiotensin 1. This angiotensin 1 is getting converted to angiotensin 2 with the help of the enzyme angiotensin converting enzyme. This angiotensin 2 is the major culprit. It will produce sodium and water retention. It will increase the BP. It will produce more refractive changes in congestive cardiac failure. So when you give ACE inhibitors, they prevent the formation of the angiotensin 2. And so that there will not be any sodium and water retention will not be there. So there will be decrease in the blood pressure, and they also prevent the refractory changes due to the heart failure. And the other advantage of these AC inhibitors is they are all nephroprotective. So when a patient suffering from both diabetes and hypertension, the important drug of choice is ACE inhibitors. Here we can see whenever, as I already mentioned you, this renin will convert the angiotensinogen to angiotensin 1. One is getting converted to 2. This is with the help of the enzyme ACE. When you inhibit the enzyme, so it won't produce the increase in BP. It will prevent the salt retention. That is because of the aldosterone. Yes, this picture you have to remember. So this, apart from this, so the problem is angiotensin 2 aldosterone. Either you can give ACE inhibitors and blocks the angiotensin 2 effect and the aldosterone effects, or you can directly block the angiotensin receptor. They are all the, as I told you, ARBs. The advantage is ACE inhibitors not only inhibit the angiotensin. Here we can see, apart from inhibiting, they also inhibits the bradykinin metabolites. So there will be more accumulation of bradykinin, which will produce dry bracy cough. This is the important side effect of captopril and enalapril. So this, to avoid these side effects only, we are using sartan group of drugs. They are also have the similar mechanism of action by inhibiting the aldosterone and angiotensin receptor blocker. Thereby, they prevent the fluid retention and salt retention. So this is again an MCQ for you. So we have the important group of drugs: candesartan, irbesartan, losartan, telmisartan. You remember. They substitute for the ACE when not tolerated due to cough. They are the mainstay of management for hypertension and heart failure. So I already told you ACE inhibitors is a separate question for you. Adverse effects similar to ACE, but there will not be any cough. They are generally well tolerated. Yes. So vasodilator is a separate question for you. So vasodilators, again, they are used where? They are used in hypertension. They are used in congestive cardiac failure. What is vasodilators? That is, they are going to dilate the vessels. So there will be reduction in the blood pressure, and they will decrease the preload and the afterload, and they are used in the treatment of heart failure. We have important vasodilators. They are the alpha blockers, prazosin and terazosin, but we are not widely using these drugs because they produce first dose hypotension and reflex tachycardia. We have the nitric oxide activators. We have seen the nitrates and the nitrates, nitroglycerin, nitroprazide, and hydralazine. In coming to hydralazine, the important MCQ, we have it will produce coronary steal phenomena. Dipyridamole and hydralazine will produce coronary steal phenomena. That is an important MCQ for you. We have the calcium channel blockers. They are also vasodilators like verapamil, diltiazem. They blocks the L-type channels and they produce vasodilation. We have seen the potassium channel activators. Again, minoxidil. Again, you have to remember this is used in the treatment of alopecia because minoxidil will produce a side effect improvement in the hair growth. So that side effect is used in the treatment of alopecia. We have already seen angiotensin receptor antagonists, losartan and valsartan. They are also vasodilators. They improve the renal blood flow by inhibiting the sodium and water retention. So AC inhibitors, either they may ask us a RAS, drugs acting on the renin-angiotensin system. We have to remember in antihypertensive also AC inhibitors. So thoroughly read the drugs, read the mechanism of action and adverse effects also. So these drugs, AC inhibitors, they produce dry cough because of the bradykinin. You should know the difference between AC inhibitors and ARBs. You should remember. And then you have to use in the important uses you have to remember. And they produce hyperkalemia also. So don't give AC inhibitors along with potassium sparing agents. I think to my maximum I have covered CVS. The one thing you have to remember is you have to read angina, hypertension, heart failure. Heart failure, another important drug is digoxin. So digoxin, you should remember it inhibits the enzyme and then there will be an increase in the calcium in the sarcoplasmic reticulum. Thereby, it improves the conduction of the heart. Digoxin carry more side effects starting from nausea, vomiting. It produces arrhythmias. It produces hypokalemia. So treatment of digoxin poisoning is an important short note. Stop diuretics. You should not give loop diuretics or thiazide diuretics along with digoxin because both will produce hypokalemia. So the treatment of digoxin poisoning is stop loop diuretics or thiazide diuretics, stop further digoxin, give them, they may go for potassium. You have to give for potassium supplements. You can give digoxin fab fragments can be given in the treatment to prevent the arrhythmia changes. Because of the hypokalemia, you can give IV lignocaine also can be given or propranolol can be given. These questions they may ask. They, for example, classify antihypertensive agents. Write in detail about ACE inhibitors. Add a note on hypertensive in pregnancy. So hypertensive in pregnancy is a two-way. If the already pregnant mother, already hypertensive mother becoming pregnant, or after pregnancy, they may develop hypertension. So you have to give drugs which are all safe in pregnancy is alpha-methyl dopa, nifedipine is preferred, hydralazine can be given, and then even calcium channel blockers should be discontinued before labor because they are all also tocolytic agents. So don't give alpha blockers, beta blockers and all alpha methyl dopa when it is in a case of hypertensive emergency. You can give labetalol, which is both alpha and beta blocker, and this drug can also be given intravenously. Drugs used in the treatment of hypertensive emergency, that is, they may produce organ failure also. You can give intravenous sodium nitroprusside, glyceryl nitrates, hydralazine, esmolol in case of aortic dissection. As I told you, both alpha and beta blocker, labetalol can be given. Yes, this is the outline of management of heart failure. So heart failure, you can give diuretics, we can give digoxin. The mainstay of management is ACE inhibitors. In case of heart failure, there will be decreased cardiac volume. Better don't give beta blockers. Only give cardio-selective beta blockers. The important problem in cardiac failure is the increased sympathetic discharge, which produce vasoconstriction and beta activation. So what you can give? You can give drugs to decrease the preload and the afterload. That is, the vasodilators can be given to prevent the cardiac remodeling, which is mainly because of the aldosterone. You can give ACE inhibitors or angiotensin receptor blockers. You can give drugs that they also improve the renal perfusion also. Left ventricular failure, we have seen in CNS, opioid analgesics can be given for pulmonary congestion and then for hepatic. So they may present with this edema features. So you can go with diuretics. Loop diuretics can be given with potassium supplements or combination of loop diuretics along with potassium sparing diuretics can be given. The one thing to remember is potassium sparing diuretics should not be combined with ACE inhibitors because both will produce hyperkalemia features. So these are all the drugs in heart failure. Inotropic drugs, digoxin, dobutamine, dopamine. So ambrinon, these are all given in case of emergencies. Ambrinon and mildrenone are again an important MCQ for you. Phosphodiesterase 3 inhibitors. We can give diuretics, furosemide thiazides, aldosterone antagonist spironolactone, RAS inhibitors, ACE inhibitors, vasodilators, necessitide, cardio-selective beta blockers not in acute condition. For mild to moderate failure as an add-on therapy, we can give metoprolol, carvedilol, nebivolol. Carvedilol and labetalol, they have the extra action of both alpha and beta action. They are also nitric oxide scavengers. They also have vasorelaxant property also. So this you can remember. ACE inhibitors, cardioselective beta blockers, vasodilators will prevent the vasoconstriction. Diuretics will prevent the sodium and water retention. We can give venodilators to decrease the preload. Digoxin, we have seen, they inhibit the sodium potassium ATPase enzyme. Thereby, they favors the income of the influx of the calcium. There will be more calcium in the sarcoplasmic reticulum, which will contract the myofibrils. But the problem is They may produce improper contraction, and there will be arrhythmic changes. Whenever there is an influx of sodium and calcium, there will be efflux of potassium. So they are more prone for hypokalemia, and hypokalemic changes also can be seen in ECG also. And thanks to the organizers and best wishes to all of you. So if you have any doubt or any queries, you can post in the group. Anyone there? Any doubt? If anyone have, you can post. Chat box unable to view. Phenytoin may cause hyponatremia also. Second gas's effect is produced with nitrous oxide. So it produces diffusion hypoxia. The oxygen will be replaced with nitrous oxide when you give to the patient. So when the oxygen is replaced, it produces hypoxia that will cause us the second gas effect. Any other doubt?
Hello, ma'am.
Yes?
Yes, ma'am. Ma'am, we will end the meeting with the Shanti Mantra, ma'am.
Huh?
We will end the meeting with the Shanti Mantra, ma'am.
Okay. Thank you.
Kindly wait, ma'am, please, ma'am.
Shanti mantra. सर्वे भवन्तु सुखिनः सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत् ॐ शान्ति शान्ति शान्तिः. Thank you.
Thank you for the session, ma'am.
Thank you, Pa. Best wishes to all of you. Thank you. We can end the meeting, Lapa.
Yes, ma'am. Yes, ma'am.